This panel, as I mentioned, is focusing on reimagining America's health data infrastructure. And as a brief backdrop, touch on where we sit today. We're years into a pandemic that not only invited but forced us all to reimagine what health data infrastructure could and should be in this country. I think I want to weave in here something I heard from Dr. Califf earlier today, one really sobering statistic, and it's an outcome, but I think it's an important framing outcome for our discussion, is that for the first time, life expectancy in the United States is less than the life expectancy in China. And I found that very sobering, and I think it's an important sobering statistic to start with as we start about talking about the health data infrastructure that supports the ultimate outcomes in our country. Physically, we're sitting in a room that is a community of practice. This is your community of practice, public and private sectors together. And all of us should be active participants in the reimagining of what health data infrastructure should be. We have to be. In fact, this is I think if you're in this room, it's part of your duty to our community to be part of this reimagining. And we're also physically sitting in the nation's capital. And this is where decisions have been and continue to be made about the future of this infrastructure. And ultimately, what is possible, realizing the art of the possible, is going to start in many cases here. So today I'm honored to be sitting on stage with several stakeholders who are at the center of a lot of those discussions. And I think what I want to start with today is just getting some definitions. So what does a reimagined health data infrastructure mean to you? And maybe I hate to do this to you, Dan, but as CDC, I'm going to ask you to kick us off. What does a reimagined health data infrastructure mean to you?
Yeah, sure. I think it's important to think right now about where we are following COVID, following the monkeypox emergence, that there's a lot that we've learned. There's a lot of things that we identified that just didn't work. And so I think for us, we really need to think when it's a health infrastructure, health data infrastructure, that new infrastructure really needs to include public health. And so I think what we've seen over a number of years is with meaningful use, et cetera, where there were the capabilities that were provided for connecting EHRs to the healthcare system, that same kind of thing wasn't there for public health. And so that connection just wasn't there. And so the new infrastructure really does need to take into account public health needs, but figuring out how can we do that. The technology, I think, is in a different place now, and so that there has to be a technology infrastructure that the public health side of things is interfacing with the healthcare side. But also, we have to address the issues that there are policy problems that prevent some of that data from being shared. And so addressing those strategies, those policies, those technologies, all of those, including partnerships, have to be together. I think for us, a successful outcome of a fully functioning infrastructure is one that takes away the burden from the clinician so that they're not sitting there filling out a piece of paper, having to fax it in, making sure that the information that public health needs is concise and that it's following the minimal data set that we need and not everything that we want to know, and collecting that in a way that's automated to get to public health, but also that once that data is at public health, they have the tools to use that data, but that information is getting back to the clinicians so that they can understand what's happening in their community. What kinds of things can they do to prevent diabetes, hypertension, et cetera? What is it that public health provides as a value back to those clinicians? And then getting that data to the national level so that we can get a quick picture of what's happening, be able to understand where we need to affect change quickly and make decisions that can help with forecasting, predictive analytics, and other things like that. So we've learned a lot of what we need. There's still a lot that we have to do. It's technology, it's policy, it's strategy.
I'm hearing a full life cycle of data, a healthy life cycle of data, making it back to the data originators, making it up to major decision makers, and making sure a lot of this is automated so we're not adding additional burden on particularly those who collect that data, but also those who have to crunch the numbers and get it up to decision makers. Maybe Allison, I can turn to you.
Sure, yeah, and I think my answer is very similar to Dan's, but the outcome that I think about is how do we get data into the hands of the people, the stakeholders across the healthcare system having appropriate access to data that they need to make decisions. And I think Dan's right, there's a lot of pieces to this. I wanted to just quickly touch on three. One is standards. I think as we're thinking about exchanging data, and you guys heard the interoperability panel, we can't get to true interoperability and seamless data exchange if we're not speaking the same language. I think we have a ways to go on technology modernization. We've made a lot of strides there, but using more application programming interfaces, continuing our transition to the cloud, thinking about advanced privacy techniques, whether it's synthetic data, privacy preserving record linkage solutions. Does data need to flow? Like, can we use data on site and access it remotely rather than having data have to move and having copies? And then the third thing is health equity, and I think it's something that we don't always think about when we're talking about health data infrastructure, but it's such an important issue. We have a responsibility to make sure that we're ensuring health for all people, including those who are underserved and disadvantaged. So thinking about things like, are we collecting standardized data on demographic information on a voluntary basis? We shouldn't be asking people to share data they don't feel comfortable sharing, but that information is so beneficial. Also, are we looking at our algorithms and making sure that we're taking out any bias or recognizing the bias that's in them so that we're making decisions that take into account all of the populations that we're caring for?
Oh, I think this is a really important point. And last year on this stage, I had the honor of moderating a panel on health equity, and Dr. Seshmani was here and spoke exactly of this, and I really love that you're touching on this point, that when we reimagine America's health data infrastructure, it's reimagining it for everyone, and it's reimagining it realizing that there needs to be trust at the most basic levels. Trust includes a real broadening of our perspective, how we handle that data, depending on that comfort level. And then I think, to your point, algorithms, everything that comes next, how are we thinking about that creatively and weaving that in across our infrastructure, not just one agency alone, but across at the state, local, and federal levels. Amy, I'd love to turn to you. Yeah.
I want what they want, but I want more. I want good metadata, and I want good paradata. So tagging on to what Allison was just saying, understanding the demographic characteristics is absolutely critical for health equity. But I also want to know whether that race response was responded provided or observed. And so those sorts of nuances in the data are going to be critical for understanding trends and building policy moving ahead. Another thing I want to tag on to is something that Jim said. He pointed out the technical and the policy issues, and I think that all of us have alluded to what I see are the cultural issues. So it's not just who is in the data, who is going to have access to the data, it's the degree to which they understand that, and that should be part of our mission too, is having more engagement so that people understand what the data are being used for. So this is like rolling out public engagement and involvement, and making sure that they trust how their data are being held, used, whether that use is for machine learning or for just generating statistics that we need to understand population health more efficiently. Absolutely. Those are some of the issues. I really care about who's going to have access to the data, which isn't quite health equity, but it's an equity aspect to make sure that it isn't just elite institutions or people that have to know how to get partnerships with the private sector. I would like to see broader access to be able to get more people using the data.
Can I follow up? Because this is the first time, Professor, you're going to have to help us. Your class data, para data. So that's the first time I've heard that. How is that different from metadata when we talk about this?
Metadata is data about the data. Paradata is how it was generated.
Oh, I love that. Okay.
So this could be, was that information collected on paper or transcribed? What was the date of the response?
Got it.
The duration?
Okay. I love this. I have not used I will be using paradata from now on, so when I'm on calls with some of you, now we all know what we're talking about. Thank you, Professor. I think one of the next questions is we're thinking about this, and I know we all got to speak before this panel, but often what I'm hearing when I speak to state, local, federal government, when I'm speaking to our providers, there's this focus on having more access to data. I'm an epidemiologist by training, so I feel a lot of empathy for this. If I could just have more data, I could build a better model. If I had more granular data, I would have more features to model off of. But simultaneously, we're at a moment where when we're thinking about reimagining our health data infrastructure, we're also being demanded of us to think about privacy. That this increase in data accessibility that we so desperately need to be able to know how disease is distributed, what we should do about it, what are the right policies, what are the right interventions. Simultaneously, we're being, the population, the citizens are asking, wait a second, my privacy, what is happening in parallel to that? And there's almost a tension, because I feel like the same person will say, yeah, I want better decisions, and I want privacy. And I think sometimes it feels like we're being forced to choose. So I'd love to start with Allison. As we reimagine health data infrastructure, how are you thinking about privacy at your agency and more broadly across government?
Yeah, I'm so glad you asked this question, because I think privacy is such an important issue. It's particularly an important issue for CMS, since we have so much data on such a vulnerable set of populations across our 3 programs, Medicare, Medicaid, and marketplaces. And there, as I mentioned earlier, there are new techniques and tools out there that can help us address privacy issues, but I don't think that they can address all the issues that we have. And I personally think when you're talking about data like the scope and size and quantity of data that CMS has, de-identification really is extremely challenging and potentially impossible. So as we think about these issues, we've been thinking a lot about kind of building on the point that Amy made earlier, how are we transparent with our consumers about how we're using their data? And I think the idea of privacy notices and that sort of thing is not new. And it's something that's come up in kind of the broader privacy discussions. But in healthcare, it's particularly important because I think people don't understand when HIPAA applies and when HIPAA doesn't apply. So when data is leaving the confines of a covered entity, people don't understand, the average consumer does not understand that decision. So how are we being really clear with them about the decisions that they're making or how their data is being shared? The other thing that we've started thinking about at CMS with our Blue Button 2.0 API, which allows beneficiaries to direct their data to applications and services that they choose, is consent. And making sure that they understand when they're consenting to having their data flow to an application or service, that they understand the choice that they're making, that they have some choices about the type of data that's flowing. Do they want their demographic data shared or just their health data? So I think there's a lot of work that's going on in this space, but it's such an important issue and we really need to keep the focus on it.
The one follow-up question I had there, on the past panel, standards was a big rallying cry there. And it sounds like you kind of just touched on that the API and standards, the privacy kind of becoming part of how we think about that. It sounds like that's something you're thinking about at the agency, that there's standards, privacy is a part of how we're thinking about standardizing data access and data involvement from the ultimate beneficiary. Yeah,
I think that's right. And I think we need to do a good job of making sure that we're thinking about how we're recording the beneficiaries' choices and making sure that they can make different choices at different times with different tools, and having standards around how we collect that information across the healthcare system.
Got it. Amy, I'd love to turn to you. Privacy. What are your thoughts? You deal with big data. You've been at Census. You've dealt with VA data. You've dealt with interagency collaboration. Privacy. Where does it fit into all of this?
That people need to click through and they need to be offered the opportunity to review and change their preferences. That has to happen. But at what point do you just remove the scales from your eyes and say, this isn't security theater, this is privacy theater? Are people really understanding what you're asking of them? Are they really understanding how the uses of their data have changed over time? Do people in the agencies, does the research community make that very clear? And so I have a complicated relationship with this. I want it to happen, but I want it to happen in a meaningful way. And something that you alluded to, Claire, is that there seems to be this tension between what I will allow done with my data. And I might have a very strong reaction if my data is going to be sold, or it's going to be used for some form of surveillance or some negative activity, but it might be really fine for other uses of the data. How are those served up to me so that I can be a savvy consumer of that information and make the right decisions? And how often do I need to be educated? Who is there to educate me on? And so I think that getting people to think about what they will allow to be done with their social media data that they might have on the back end, like Google search history, as opposed to, yes, please use the fact that I'm fully vaccinated and vaccinated. Whether the data are being used for statistical series or they're being used for commercialization.
I think that's super interesting, and something I think in this community, privacy feels like it is in every conversation I've been having, and I love this distinction. My preferences and then population preferences. Again, I gotta go back to EPI where we talk about personal risk preferences. When infectious disease, we all lived with COVID, whether you're wearing a mask or not. Your personal preferences versus population and regulations. And what is the adaptable way that we communicate? Here's how you can make decisions for you, but then as a community or as a society, these are the decisions we are making. I think that there's an analogous here with privacy. We need to be leaning into educating people about personal preferences and also thinking about regulations for communities at the population level. Dan, I'd love to turn to you. Privacy, I'm sure this has come up for you.
Yes, and not just for us, but at multiple levels of public health. But as we think through what is right for the individual, what protects their identity, we have to be sure that it doesn't prevent the activities that help protect the population or even just the people around that individual. And so there are different PII needs at different levels of public health.
Right.
We know that if you have a measles case, you need to know who that is so that you can do something about it, but I don't need to know that at the federal level, but the local health department does need to have that. So if we're thinking about kind of technological solutions and policies, we have to think about what's going to maximize that patient identity protection, as well as maximizing interoperability, so you don't want technology solutions to be difficult, as well as maximizing that public health impact and public health activity. So that is a challenge. And so there are technological solutions that we have that we've implemented through different kinds of technologies at CDC. There are some that we've tried, I think, at the local level too, but we need to make sure that the action that has to happen by the locals is maintained. And that aggregate information that we may have at the national level allows us to see what those trends are, maybe even see what's happening immediately, but not have to know who all those people are. So there's technological solutions, but we have been working working a lot, frankly, with ONC on what does that kind of ecosystem look like? And so we've tried to say, what does a North Star architecture look like? What are some ways that data can come together, be protected, be accessible to different people at different levels of access so that we can do the work that we need to do in as efficient a way as possible. And so those are our challenges, but maximizing that patient identity protection, that interoperability, and that public health action, those are things that we really need to figure out.
I hear this very sensible approach on how this can happen for health and public health, but adjacent to that, you have justice. Adjacent to that, you have housing. Adjacent to that, you have workforce. Yeah. And if all of these domains are optimizing within their own data systems, it's very difficult to really take these steps forward for social determinants, because when you have adequately protected individual and group identities, that may have made the data completely useless when you're trying to bridge it to these other domains. So I think there's a lot of system level work that we also need to do.
Oh, absolutely. I think this is one of the big conclusions coming out of the pandemic. We all looked and said, oh, all of my data is my health data. My health data is whether I have a car, whether I can get out of work, whether I can work from home, my education level, et cetera. I mean, all of this is health data, but not regulated under the same things. Privacy frameworks are different, et cetera. So it's system-wide. I think privacy is a system-wide when we take that system lens on health. One thing, and I think when I was listening to you all talk about your reimagined health infrastructure, I mean, really, Dan, like this full circle, this is the dream of public health, right? A full circle of life cycle for our public health data, et cetera. I'm interested in, I think before the pandemic, I might actually say some of the dreams that we've had are pre-pandemic dreams. We've been dreaming about a reimagined health infrastructure since before the pandemic. I'd love to just double click on the pandemic for a moment. What about the pandemic specifically forced us, if there was one thing one specific way the pandemic challenged us and requires us to re-examine or reimagine this health infrastructure, what is that one thing for you from where you sit? Maybe Amy, I can put you on the hot seat first this time.
Will we be able to come up with new norms that allow data to be shared responsibly
I mean, one way, I feel like you can have a few.
Okay. Yeah, I think that you mentioned the technology and the policy issues. Again, the technology is in a different place now. We also have gotten things because of the pandemic that we didn't have before, and there is some expectation is that, oh, that's the way it has always worked, when in fact it isn't. And so we have been able to overcome some things, both policy and technology, but those have to be sustained. And so, I mean, one important thing is the resources to be able to sustain that both at the local, state, and federal levels, so that we can maintain a level of public health activity, monitoring, intervention that we just didn't have in place the way it should have been at the beginning of the pandemic. So that resources, but also the policies. There are things that need to be changed. You know, when we had the pandemic, some of us in the room actually worked on some of that stuff early on, but there was not the ability to say, this is the information you need to give right now. We had to work through different policies at CMS, through CLIA, through all kinds of different gesticulations to actually get that data to come through. Getting that common set of reportable elements, a national requirement for that reporting, but also accounting for the needs at the various levels of public health. Working through those policies, I think, would make it a ton easier for the next pandemic.
Taking things in maybe a slightly different direction, one of the things, CMS does a lot with interagency data sharing, and I think data sharing in general is such an important issue, but another thing that came out of the pandemic for us is our comfort using really timely administrative claims data. It's something that CMS historically has just, we've wanted to let the claims run out, understand all the changes that are going to happen before we analyze the data, before we share the data with researchers. And I think when the pandemic hit, there was just this demand, even though we know that the claims aren't real time, that we're not going to have all of a complete set of information, let's at least look at what we have and what we do know. So speeding up to using, you know, near real-time monthly data, both internally within CMS, but also sharing that data with researchers through our virtual research data center, is something that just changed pretty quickly with the pandemic for us.
Absolutely. I mean, I feel so. I did my graduate school work on surveys, and surveys in the middle of a pandemic that's changing day to day, it's very hard. So we've had to reconsider timelines and what types of data are appropriate in different situations. What ways there's a lot of private sector constituents, private sector community members in the room. I'd love to hear from all of you, what are the ways the private sector needs to actively contribute to reimagining America's health care infrastructure? Congressman Peters kind of challenged us all to be, I think one thing he said was read some of the legislation that's coming, some of this refunding of certain data systems. I think we've already got some homework, but I would love to hear from each of you, what is one or two things, concrete things this room needs to take if we're going to actively contribute to this reimagined infrastructure? Also, maybe we'll go the reverse way this time. I'll start with you.
Sure, yeah, I have two. So the first is, there is so much data out there in the health ecosystem, everything from claims to EHRs to wearables, and as a consumer, as a caregiver, as a provider, making sense of that data is challenging. So continuing to build tools, resources, that sort of thing that help an individual, whether it's a consumer, a caregiver, a provider, use data effectively. And the second, going back to a point I made earlier, is keep the momentum on health equity. I worry that we get distracted by other things, whether it's technology solutions or other policy issues, and it's just, we can't lose the momentum that we have on health equity. We saw with the pandemic, the just disparities that occur in our health system, and we need to keep pushing on that.
Yeah, I think at CDC, as a part of certainly what we're doing recently here with our director's new CDC Moving Forward initiative. If folks have interest, you can look it up online. A lot happening there about how we do things differently. And so as a part of data modernization, we've really been engaging and want to continue and do more engagement with industry, with the healthcare sector. I think one area that it would be really helpful is participating in the standards development. There's a lot that's happening, was mentioned in the last section, that of US CDI Plus, making sure that that actually is done correctly. participating in our HL7 Fire Accelerator, helping us figure out exactly how we do TEFCA as a public health community engaging in that kind of trusted network. And then we are moving into a space where we're looking at public health data system standards and certification. And so that's an area where the EHR side of the house has been thinking through and dealing with that for a while. How is it that we can do that on the public health side? And there are solutions that industry healthcare has that would be very helpful there. The last is just there's so much data, like you just mentioned, and there's a real need for us to be able to have an easy way of getting to information to say what's a trend that's happening, what's emerging, but also once something has emerged, how effective are the vaccines? How effective are the diagnostics? How effective are the therapeutics? What are those kinds of engagements that we can have, the kinds of platforms that are available that would allow for asking those questions quickly so that we can get that information for forecasting, for modeling, for all kinds of things that can help us act more quickly in a pandemic.
And read the North Star infrastructure. That's a really important plan. And if you need the Spark Notes, you can email me. I'm happy to help if you don't have time to read the whole thing. We have our homework, all of us in the room. I want to thank our panelists. This has been a fantastic discussion. And thank you all for listening.